Hi, it's Dr. Somji. Welcome back to the channel.
I'm Dr. Solomon. Welcome back.
We're going to perform a treatment that we do every 15 minutes on a non-surgical day. So obviously it's commonly known as Botox, but the actual name is botulinum toxin. And this is a concept that people say, well, like, I don't want to look unnatural. I don't want to look frozen. I want to look natural, still want to have some movement. So we both have Botox and we still look really quite natural. Mine's kind of wearing off, but I still got less movement than I had. I look a little bit more fresher. So this is what patients want to come for. So we're going to tell you what happens with it and also look at the pitfalls that you might have experienced with your current injector. And actually it's really simple. It's a really simple fix that you can do. So we're going to separate it down. We're going to talk a little bit about anatomy, why you may not be getting what you want to get with Botox, and how you can get the best out of your treatments as well.
So before we talk about anatomy, question we always get asked, what is Botox? I want the most natural results. Give me a natural treatment. So to that I answer, and you answer, Botox is natural. It's actually one of the most natural treatments available in medicine as a whole, and certainly in aesthetics. Yeah. That is because botulism toxin is a natural toxin from a bacteria, the same bacteria that actually produces tetanus. Now it is the opposite of tetanus in its effect. So there is a bacteria, the Clostridium family of bacteria, produces two main toxins, tetanus being one, which of course we don't use for medical therapy or in aesthetics, and there's botulism toxin. So in massive doses, botulism toxin can be quite toxic to the system. Now, we're using in aesthetics in micro doses to that very same effect, to paralyze a muscle, which is actually its toxic effect, to paralyze a muscle, but only where we inject it. And that is the effect of botulism toxin or Botox. We are paralyzing a muscle to soften wrinkles.
And just remember, there's no such thing as Botox wearing off. Okay, so what Botox does is that you've got two different receptors between your nerve cells, okay? And if you have a stimulation to contract, so your body says, I want to contract my bicep, it will say, yeah, it'll send an electrical impulse from one nerve ending to another. Botox sits in between and blocks that. So you want to contract it, but you can't. What happens is that your body goes around that. So it actually creates new receptors to go around, and that takes about 3 to 6 months on average in a human body. So the actual Botox actually stays in there for a year and then it degrades. But obviously the effects wear off a lot sooner than that. So when people say my Botox has worn off, it's got nothing to do with the Botox. It's actually got to do with you. So Anna's very young. She's only got very faint lines in this area. Can you see these horizontal lines? This muscle that controls this thing is obviously called the frontalis, and it helps lift the brows. So can you lift your brow for me, Anna? Can you see? It's very faint. Can you see? So actually, she's been having Botox like regularly for years, so she's actually not got these ingrained lines. This is almost like a touch-up treatment that we do. But if she first came and saw us, we'd probably say actually it's not severe enough. But we know that if she leaves it another 3-4 months, the lines become ingrained, and that's something that people don't want. So it's like a preventative treatment. So if you're going to put Botox in a muscle that raises up and Botox relaxes that muscle, what's the net effect going to be, Dr. Solomon?
You relax the muscle, you relax the lines, you soften the lines. And that is ultimately our goal here.
Exactly. So if you just relax it, so some people say, well, I'm just going to inject the muscle in these areas, and you don't do anything to kind of counteract that, the patient will feel heavier like this. So just note, this muscle, the elevator muscle, the frontalis, is a lot bigger than the complex of muscles that sit here. And these are the muscles that bring things down. So you've got a muscle in this middle area that pulls things down, and then you've got this muscle that brings things up. It's also an interplay because this muscle that sits around the eye, it's called the orbicularis oculi muscle, also depresses the eye too. So close your eyes really tight. Can you see you've got that inward motion that comes across this area all the way like this?
So you have quite strong forces pulling everything down. So what we have to be careful of when we inject any forehead is that we don't lose all of that lift, and if we do, we need to counter it.
Exactly. So if I inject Botox into these muscles, you will get the opposite effect. You'll get a lift. If we inject in these muscles, you'll get a drop. So in a female brow, we want something like that. So although she's got hyperactivity within this muscle is very strong, we want to inject toxin in there, but not too much. and we want to leave some movement because she's going to come back and say, my brows are too heavy. And that's a common fault that people have.
And we have nobody who comes in and says, I want sort of lower brows. In fact, everyone wants a raise. Everyone wants to have slightly higher brows and to have a lift.
So yeah, so like in this case, if she wants to remove these lines, the horizontal lines, and get lift, it's actually very difficult to achieve that. And that's one of the that's one of the things that toxin can't do. That's all got to do with her brow in this area. And you may want to look at, for example, a surgical brow lift, or if someone's got very loose skin in this area, an upper blepharoplasty. She's obviously very young, so we don't need to do these type of things. But it just means that we need to do what's called like baby Botox. So like smaller dosing over wider areas, just so that she leaves some movement and the eye doesn't feel so heavy.
If we could just ask Anna again to raise her forehead, you'll notice that Anna actually has muscle, the frontalis muscle, the lifting muscle across the entirety of her forehead. That is actually the most common type, but there are 7 subtypes of that frontal muscle.
Absolutely.
We won't go into the details now.
Look at our training series.
Training series coming soon, and we will go into the nitty-gritty of all of that. There are 7 types, and there are several other types of the depressor muscles. But just of note, this is the most common type, and it is the one that you'll see most in clinic.
Just remember, look, these muscles are very close to each other. So frown for me, Anna. You've got the glabella area over here, and then you've got the medial and your lateral corrugators. Frown again. And you can see the insertion of the lateral corrugators into the skin here. The medial corrugator sits there, but they're quite low down. Now raise your brows. You see her frontalis is just there. So when you're injecting any form of Botox, you've got literally probably about 2 millimeters gap. So you can't have the product spread. And what I normally see is if someone's not very careful with the injections over here, you'll get this sort of look going on where this actually goes down more. And that muscle normally sits actually here. So a lot more lower than you think it is.
Almost into the brow.
Exactly. Some of the pitfalls, if you inject too deep at this location, not in the skin, there is some evidence anatomically that you can get dispersion of the product into this levator palpebral muscle, and you can end up with a lid ptosis. So wink your eye do a little wink, so the eye will close, and you'll see that you're the lid ptosis, which is kind of a terrible side effect.
But reversible.
But reversible, you can actually inject that muscle over there, the actual lid, to lift it up. And also you can have some eye drops that also help you use another muscle to open up the eye too.
And in fact, one of the reasons Botox is so popular, as well as being natural and very effective, is that it will wear off. A lot of fact of what we do is reversible treatment and treatment that will wear off. So not having permanent treatment in the face is desirable in the event that the aesthetic look changes, or for whatever reason the individual doesn't want that look anymore.
Yeah. So just remember, in the UK, we charge by Botox by area. So this tends to be like one area here. Around the eyes is another area, and the forehead's another area. In the States, it's by unit. But unfortunately, in the UK, people force people to try and get 3 areas because they charge more for it. But sometimes, if someone just wants a raise of the brow and an opening of the eye, you don't need to treat 3 areas. You just need to do 2. You can omit that area actually quite nicely. And that's, again, a pitfall that people fall into, and they feel very heavy with their Botox. So look, every Botox treatment has to be tailored to the exact patient, and you need to know about your risks of having heavy brows, and also what you want from the treatment. Do you want to look a little bit more weight? Do you want to look more fresher? And then we tailor the dosing accordingly.
So what we'll do, we'll mark up the areas that we intend to inject. I often start with the depressor muscles. So what I'm going to ask Anna to do is frown for us. Stronger frown if you can. So you can see Anna's frown's not that strong, but I can identify where the muscle contracts just about there. And then frown one more time. And you can see the depressed muscles there. Now, as Dr. Somji alluded to earlier, we want to be sure that we're in that muscle and we don't overlap with the lifting frontalis muscles, so that we don't cause a double dip. Again, one more time, frown for us, and there it is again. So what we want to also try and aim to stay is towards the midline from the pupil line, because if we go further out, we risk the Botox trickling down into the eyelid muscle, which attaches just there. So if we stay to the middle of that line, more towards the nasal side, we reduce that risk.
Also, like there is a study saying how high you are with that, right? So you have to be above the brow, but the eyebrows are not an anatomical landmark. It's the orbital rim, and our orbital rim sits like here. So being up here is absolutely fine. So yeah.
Okay, and just frown for us again, Anna. There we go. Okay. Now, in terms of the forehead, depending on how you inject, depending on the amount of volume inject and units you inject, you can inject anywhere from between 4 to 8 injection points. We referred to earlier about different types of forehead muscle, and there are the 7 types, but in Anna's case, her forehead muscle spans the entirety of her forehead, so we will have to be quite diffuse in our injection points, but very small injections at each point, because what we don't want to cause is a drop in the forehead, but we want to soften the lines and we want to prevent feature lines as well from forming. So what I will aim to do here is to draw a few lines across the forehead, spanning the entirety of the forehead and just covering the upper part of the forehead, but not going too far down as well, so you have some of that lift remaining there. And if you see in Anna where there are dynamic lines, Anna, if you could just raise your forehead for us, predominantly over the upper part of the forehead where she has a straight.
Yeah. So don't forget, like, just raise for us here. Have you ever seen spocking? If this area of the frontalis is not relaxed, she's definitely liable to spocking on this side. I can't see the other side, but you can see that. We call it comma lines as well. So if you just treat the top bit and you don't do so much coming down, you're at risk of that. So it's like a catch-22, right? So frown for me a little bit, angry, down. So like sort of medial corrugator, lateral corrugator sitting there. This one, you know, I think you've injected it because you think, well, you want to avoid that sort of spocking, right?
Yeah, in fact, I do. And also what I tend to do, I inject above the dots that I marked.
Yeah.
I try not to inject into the dots. So if I'm going to inject up here, I will mark just below it. The reason being is just, you know, I'm always paranoid about potentially injecting a chalk into the skin or
yeah,
into the skin.
you can actually, if you go through one of these, you can definitely tattoo the patient, because that's what tattoo is. So, and you see a lot of people with little dots in the area instead of white dots, and actually it's because of it having repeated Botox injections and people injecting through the dot.
Let's mark out the frontalis. So, and if you could raise your forehead again. Okay, so. And Dr. Sanji, I'll let you mark out that outer part there.
Right, for me, yeah. There we go.
Just there.
Yeah, that there.
Just there.
So you're doing 2 rows, right?
Yeah, I prefer to do 2 rows when the forehead does extend. The front forehead muscle extends all the way to the start of the hairline. In some cases, you'll see that the forehead muscles stop just about there. So it all depends. There is no one protocol, one template.
Don't forget, you know, your Botox is going to spread about a centimeter from every area that you do it.
So you have a
So, and that's a field of effect. So if you're going to have a hyperdilute area, it will spread a little bit more. If you're going to have something that's injected at pressure, it will also inject more. So injecting at low pressure, which we're going to do with an electronic injector, the first of its kind, you're going to have very precise dosing that you can do baby dosing within this region. So close your eyes for me now, Anna. So now look, she's got things that pull down. So if we want that little fox eye look, we're going to do that. And people want that because it helps open out the eyes. Okay, now smile for us, Anna. Big smile, biggest. Can you see now she contracts this area? In this area, if you relax this too much, you can get a little drop like that. So beyond this medial area, I would say is not good to inject. So look, these 2 lifting ones have really done it. Maybe a 3rd injection just to help lift. So she's gonna get a little bit of drop because we're injecting the forehead, but because we're gonna be lifting with this, it's gonna help counteract it. And that's the balance of toxin injections. That's like an art, really.
Yeah, and you referred to earlier this muscle, the eye muscle, the orbicularis oculi muscle, being a depressor muscle.
Yeah.
I see it also as a purse-string muscle, so it actually ties to the whole area. So what you get this perceptive opening of the eyes as well.
Yeah.
Actually, very good feedback from individuals who have Botox feeling that they feel more open, not just look more open and not just softening lines, but they feel more open as well.
Yeah. So we're gonna fire up a little electronic injector device. So we've gone through this. We're going to actually inject very small amounts of units. These are what we call Spaywood units for Azilo. I like Azilo because it lasts longer than the actual brand Botox. And it's proven to also last longer in literature. And also you can be very precise with it. And with this JuvaPen device, you can be super precise. So we're actually going to inject like 1.25 units per little bit over here. And you can see how precise it can be. So you can hold it within this hand, and you always face away from the area. So I'm just coming underneath the dot, and I'm very superficial in that area. So you can see that very small amount that was injected. And you can see a little flab there too.
And that precision, can it be achieved manually?
No, you can't do 1.25 injection, that's just too tiny. So look, and here, look, this muscle is, the orbicularis muscle is just actually adhered to the skin. So I can really concentrate on the depth that I'm doing within this area. And again, look, there we are.
And you leave the volume to the machine.
Yeah, so traditionally people say, oh, okay, always inject away. But if you've got an electronic device, there's no way you can put that pressure in to go beyond that. Now in these areas, I tend to do like 2.5 units. So we're gonna change it on our function. And that is injecting 0.0126 mil. So can you say that you can do that every time?
I would struggle to even get double that amount in one injection.
Exactly. Perfect. So I'll leave you to do the other 2.5s. That's it, no problem. So this is like a dual treatment. We'll see which side is better after this. So, Dosson, you go a little bit deeper in that region.
I do. I tend to go more on perception.
Yeah.
Often what you'll find is where there is more bulky muscle, and if you remember in Anna's case, Anna, could you just raise your forehead for us again? You'll see that there is a bit more
Yeah, so
bulk
like in
there.
that bit there was a little bit more bulky.
Yeah.
In fact, it's more bulkier that side than it is on this side.
And that may be simply because she has more weight on this eye and eyelid, and the frontal muscle is actually compensating for that. It may just be a genetic variant as well. So, okay, just under the skin there.
And then the second row, we're going to do like half the dose, right?
Yeah.
So we're going to switch it up. So we're going to go down to 1.25 again. And then we're going to look as well. So we're going to see, okay, fine. We've got this little area here. Come in.
You see our strategy here is more injection points, but fewer units per injection point.
Good. Perfect. I'm just going to do this one, which is the one that you said, the lateral corrugator. She's got this little kind of spot that's sitting there, so we're just going to come a little bit higher than that and just in the skin, and that's perfect, and that's been perfectly delivered in that area. And that's that. I'll go down to 1.25 so you can do that lower.
Let's finish off on this one.
So do you feel like you got more control with the electronic injector because you can see the depth, right? And you
I
don't
feel
even have to look. What
absolutely. Yeah, I feel I have to worry less. Worry
Yeah.
may not be the right term, but think less about the actual volume and focus more
Yeah.
on the delivery of the anatomically correct spot and also the depth.
Yeah.
So we're just going to inject over here. So they're just above here.
And I notice you're not pointing towards the eye, you're going away from the eye in that area, right?
And similarly in this one here. Just go away from the eye. So you have less of a likelihood for it to travel
Anything
down.
traveling down. Okay, perfect. And I think we just
just got
have
to
that
do
one
this.
there remaining, which I think you probably could have done, but it's fine.
Yeah.
I'll do it.
If we're of course injecting alone, we would swap sides and
Yeah, that's the first like dual treatment of Botox I've ever done. So it's a great moment.
it's a
Tina.
first for me too.
Yeah, it's a first. It's a first.
And then we have the what we term the procerus muscle. It's actually one of the strongest muscles.
Procerus is really strong for bringing
very
things
strong.
down, right?
So we would need to up the dose there.
So you're upping it to like 5-10 units.
5 to 10
right?
units, yeah. So because Anna's is quite delicate, she doesn't have a.
We've done smaller dosing here, like it's
Yeah.
tiny dosing.
We'll just ask Anna to frown again. You can see it just about contract there. You see, if you ask a, let's say a frowning male who has built up that muscle over many, many years, we may double the dose that we use in this area. So the injection technique for this muscle, because it's quite a thick muscle, you can actually go straight in and then deliver that Botox into the actual muscle. It's probably of all the injections, the deepest injection that we will perform.
So just note now, no really touching or rubbing of the area. I am rubbing, but look, I'm rubbing away from the area. So I'm gently cleaning away. But because the injections are so precise, we don't want to really move from the area which Botox is injected. So we're just slowly cleaning off all these little marks that we made on her face and any blood spots, just to make sure that she's socially acceptable. And always away from the eye. And then just generally no exercise for the next like 6 hours, no excessive leaning forward or leaning back, and no real rubbing in a downward direction, which I was.
There is one final spot here that
Alright,
I
go
need
for
to
it.
just finish off for Anna. Just over there. There we go.
Perfect.
Okay. So, you know, in terms of patient experience, I have found with this device significantly less pain.
Yeah, definitely. And more
Yeah.
standardized treatments.
Yeah.
That's the benefit. Yeah. I mean, you saw a difference, right? Because you
Yeah.
have it.
Much
You've had it
difference,
both.
yeah.
Yeah.
Couldn't feel anything.
Yeah. Yeah. Well, sometimes you feel something.
Like
Yeah,
maybe
okay.
tiny bit.
No, we don't want to like glamorize it here, yeah?
Compare it.
Okay. Some people like me got low pain threshold, but yeah, it hurts less. That's what it is.